Picture this. You're dispatched to a cardiac problem at about 10 p.m. You get on scene to find the patient watching TV, waiting on you. He's alert and complaining of lightheadedness. Your partner checks vital signs and you see him get this confused look on his face. He looks over at you and says, "I can't find a pulse." Can someone be generally fine, totally awake, and pulseless? I'm Angry Bill, this is Prehospital Wisdom, and I have an EMS scenario discussion for you. I really hate it when you come across a post or a video that has a great scenario, a fantastic question, or bizarre EKG, but the creator doesn't give you an answer right then. Usually, I never get an answer, only hypocognitive comment guesses. So we're going to discuss this whole case and lessons here and now, no waiting for another post you might never find. Now, where was I? You were dispatched to a cardiac arrest call. You get on scene, you find a 65-year-old male sitting up on his couch watching TV. He's alert, oriented, and tells you he just felt a little lightheaded and fatigued, especially when he stands. Your partner tries to get vitals, and he looks like he's trying to divide a fraction by a decimal inside his head. He can't find a pulse. You try the other wrist. Nothing. You feel for a carotid. Still nothing. All while the patient is looking right at you, asking if someone can fetch him a glass of water. Your initial findings look like this. The patient's alert and talking. His complaints are fatigue and mild dizziness. Vitals are pulse, none felt. Blood pressure, nope. His pulse ox, not getting a reading. Respirations are 18, that's sweet. His skin is warm and dry, and his cap refill is about 2 seconds. Mental status is normal. He's oriented ×4 with humor. And you hear something strange. You hear a quiet mechanical humming sound from his chest, especially when you auscultate his clear breath sounds. Every single protocol we learned starts with check for a pulse. That's how I introduce myself. This guy doesn't have one, yet he's talking to you. What's going on? So that's the information you have to work with. This isn't science fiction. These people happen, and they freak out medics who aren't prepared. Pause the video now if you want to take a second to think about what could possibly be happening. I'll come back in 3, 2, 1. All right, what the patient wasn't telling you was that he has left ventricular assist device, or LVAD. And today we're going to break down exactly how to deal with LVADs in the field. They can be weird. An LVAD is a mechanical pump using an impeller to move blood. I love it when medical terms say precisely what's going on. An LVAD is assisting the left ventricle. A tube sucks blood from the weak left ventricle. It flows through a rotating impeller pump and is ejected through another tube into the aorta to go to the rest of the body. They implant them in patients with end-stage heart failure as a bridge for transplant or for temporary support while the myocardium heals after, especially severe damage and stuff like that. Now, the key to this whole no pulse thing is how LVADs work. Your heart creates a pulse, a pressure wave, by contracting and relaxing, systole and diastole. Think of it like a wave crashing on the shore. But LVADs provide continuous flow. It's not a wave, it's a river. The blood is always moving. The smooth, constant flow is great for perfusing the body, but it doesn't create that thump that we feel as a pulse. It's why automated BP cuffs and auscultated manual BPs can't get a reading. There's no thump, there's no carotid cough sounds. That's why this whole scenario is possible. You can have a patient who is talking to you with warm pink skin, who is for all intents and purposes stable, but has no radial pulse and a blood pressure that reads error. It's not a sign of a dying patient, it's a sign of the machine doing its job. As a matter of fact, there are even case reports of people with LVADs who are in asystole for extended periods of time, even without knowing it. They don't know that they're in asystole because the LVAD is working just fine. All right, so if our traditional vitals are out the window, we have to change our assessment strategy. Your primary goal is to determine perfusion. Forget the pulse check. Instead, you rely on classic clinical science. Treat the patient first. Look at their mentation. Is the patient alert and talking to you coherently like our guy on the couch? I'm not sure asking for water is coherent, but whatever. Are they confused, lethargic, unresponsive? Good mentation is a fantastic sign of brain perfusion. Next, assess their skin. Is it warm, pink, and dry? Or is it cool, pale, mottled, clammy? Good skin signs mean blood is getting to the periphery. Check their capillary refill. A brisk refill under 3 seconds is a positive sign. If you have capnography, this is a crucial tool. An end-tidal CO2 reading over 20 millimeters mercury is another solid indicator of adequate circulation, especially past the lungs. Gas is being exchanged. Once you have that clinical picture, you can try to get a number for the mean arterial pressure, or MAP. You can calculate a close estimate of MAP by adding the systolic to twice the diastolic and dividing by 3. But this is constant flow, no systolic or diastolic, so you can't do that. Another way is to look at the number on the monitor after an automatic NIBP reading. Again, that won't work on an LVAD patient. If you like, you can try to get a manual MAP. The gold standard for this is a Doppler. Put a manual cuff on, place the Doppler over the brachial artery, and inflate until the LVAD's whooshing sound disappears. Slowly deflate, and the number with the whoosh returns is your MAP. The target is usually 70 to 90 millimeters of mercury. Don't have a Doppler because maybe you work on an ambulance? You could try to use your pulse oximeter. I've never done this, and the instructions are confusing to me. You're going to have to look this up on your own. It involves watching the pleth waveform disappear when the BP cuff is inflated and returning when it is deflated. But there's no pulse, so I wouldn't expect a pulsatile pleth. If you've done this, please explain it to me in the comments. Like, it makes no sense to me. Anyway, once you've checked out the patient, you have to check out the machine that's keeping them alive. It's a simple, systematic check. The very first thing you do is listen. Put your stethoscope right over the left side of their chest or upper abdomen. You should hear continuous mechanical hum. That hum is the sound of the impeller pump spinning. Hearing that hum is a very, very good sign. If you hear silence, that's a true emergency. Next, trace the lines. There's a cable, the drive line, that comes out of the patient's abdomen and connects to an external controller. Make sure it's plugged in tight. That controller is the brain, and it's connected to batteries, usually worn on a belt or in a vest. Look at this diagram from a paramedic text. It looks like old school detective shoulder holsters, and I love it. But that's what you're looking for. Finally, check the controller for any alarms, low flow or low battery or critical clues, and check the batteries themselves. Are they clicked in all the way? Most have an indicator you can press to check the charge. You know how this is. It works on a life pack as well. A dead battery means a dead pump, which can mean a dead patient. All that's bad. Let's break down how to manage this with 3 different scenarios. Scenario 1, the stable patient with adequate perfusion. This is our guy on the couch. He's alert and talking. His skin is warm and pink, and his cap refill is brisk. Even without a Doppler, your assessment tells you he's perfusing well. You listen to his chest and hear a good, strong hum. The LVAD controller shows speed 5,200 RPM, flow 4.5 liters a minute, power 4 watts. I don't know if those readings are normal, but the device is humming. That humming sound is good. It means the pump is spinning. What do you want to do for him? Pause if you like. My answer in 3, 2, 1. In this case, there's no need for aggressive intervention. Your job is to perform a device check, reassure the patient, and arrange for transport to their designated LVAD center. Maybe consider a fluid bolus because you need fluid to pump. Dehydration lowers preload, lowers pump effect. But this is a heart failure patient, so don't go hog wild with that. Evaluate if dude has had fluid loss, like diarrhea or vomiting, and ask about his intake. Evaluate other causes of lightheadedness from ears to brain, hypoxia, hypoglycemia, and all the rest. The pump seems to be working, so take a sigh of relief and figure out what else could be going on. So let's change things up with the second scenario. You find a patient now who is unresponsive. Your perfusion assessment reveals their skin is cool and pale, and your end-tidal CO2 reads 16 millimeters mercury. The cap refill is very delayed. Those are all signs of poor perfusion. But when you listen with your stethoscope, you hear a loud, steady hum. How does this presentation change your care plan? Pause and wait for the answer in 3, 2, 1. You didn't pause. I know it. So anyway, the auscultated LVAD hum tells you that the pump is working, that something else is wrong. Do not start chest compressions even though the patient is pulseless and unresponsive. Bizarre, right? Your threshold for chest compressions is apnea. The problem isn't the pump. It could be severe dehydration causing a low flow alarm, hypoglycemia, GI bleeding, stroke, all the other things that cause altered mentation. Treat the potential cause. Consider a careful fluid bolus, check a blood sugar, all that jazz, and transport immediately, probably flashing and making a lot of noise because you are very uncomfortable with this patient. The third option also involves an unresponsive patient with no pulse. Their skin is mottled and cold, cap refill is delayed, and end-tidal CO2 is below 20. You listen to their chest and hear nothing, no hum. What should you do? I shouldn't even pause. I know you're not going to pause. This is the ultimate emergency. The pump is not working and the patient is in cardiac arrest. The 2025 American Heart Association guidelines are clear. You must start chest compressions in this case immediately. While that's going on, start working to troubleshoot the LVAD. After confirming the driveline and batteries are connected, if that pump isn't running and perfusion isn't adequate, immediate high-quality CPR is the standard of care. The old fear of dislodging the device is no longer a reason to withhold compressions. Start pushing on the chest. Your most valuable resource on scene is often the family or caregiver. They live with this device 24/7 and have been trained on it. Listen to them. They know what's normal for the patient, and they'll have the phone number for the LVAD coordinator. Hopefully, they know where the extra charged batteries are, right? Another point is that all LVAD patients are on a blood thinner. It matters during trauma, of course, and if they aren't keeping up on it. It's unlikely, but we see everything in EMS, right? So if they aren't keeping up on it, the pump can form clots. Then PEs and strokes and all the rest become a big problem for you. Hopefully, most of these people know that this machine is keeping them alive and they need to follow the instructions and all the medications. For all these cases, the LVAD will have a number on it to call an expert, the LVAD coordinator. Call that number. They will know how to troubleshoot, where to transport, and all the rest. The LVAD coordinator is the specialized nurse who is your lifeline. Call them early. They can give you their specific advice for their patient and that monitor or that model of LVAD right over the phone. That's what you want, is that extra help. Enlist that. And before you go anywhere, you must remember to find the patient's go bag. This bag has a backup controller and spare fully charged batteries. Leaving this bag behind is a potentially fatal mistake if something fails during transport. Hopefully they were smart enough to build one, and hopefully you can find it and know where it is. Finally, think about where you're going. If the patient's stable, like our guy on the couch, they need to go back to the hospital that put the LVAD in, even if it's a longer drive. That's where the experts are. But if the patient's crashing, you go to the closest appropriate ED. Do you know what they'll probably do? Call the LVAD coordinator and ask, what should I do? Sorry, I don't mean to be disrespectful. That's probably it. So let's circle back. That patient with no pulse isn't a medical mystery. He's a testament to some incredible technology and modern science. And once you understand the system, these calls become a lot less scary. Let's summarize the key points for you. 1. A conscious LVAD patient without a pulse can be completely stable. That's a normal finding. By the way, there are case reports of stable patients being asystolic. 2. Assess perfusion using clinical signs, not vital signs. Mentation, skin color, temperature, cap refill, and tidal CO2 are more important. 3. Do a quick device check. Listen for the hum and check all connections from the patient to the batteries. 4. And the big one, in an unresponsive LVAD patient, your next step depends on the hum. A steady hum means find and treat other causes. Silence plus poor perfusion means start chest compressions. So what do you think of this? If you like this kind of EMS content, do all the YouTube stuff that you hear about on every video. Liking, subscribing, and sharing doesn't cost you anything, but they mean everything to me, and I'm profoundly grateful for you. I'm Angry Bill, this is Prehospital Wisdom, and until next time, check for the hum.